Okay, well, thank you everyone for having me giving this reflection on my experiences on digital and computational pathology today. And of course, a special thanks to Dr. Veena for actually inviting me to participate in this session today. My apologies for not being able to be live there with you at the moment, but I thought that perhaps I could share this video with you and hopefully you enjoy my talk today. So my name is Juan Tamero. I'm an anatomical pathologist and I am medical vice president for Page. I've been with the company approximately 4 years. But before then, I was practicing in one of the first labs to have gone fully digital for primary diagnosis back in Spain. This is something that we did back in 2016, actually. So that totally changed my career from being a normal pathologist to essentially becoming a consultant in digital transformation and AI implementation. And as I said, I've been with Page for approximately four years now. Reflecting on the impact of digital pathology in itself, digital pathology on pathologists, it is worth mentioning that digital pathology brings about a series of advantages in itself, even without the application of artificial intelligence. And these experiences can be summarized in these two papers. So the first thing that is worth mentioning is that, well, the first paper that you see here essentially is a how to go digital. This is a reflection of how we transition from the microscope to a full digital workflow. Also, in that paper, we reflect on the changes in efficiency associated with a digital workflow, which in fact, in our situation, resulted in an improvement in efficiency of about 20%. Number of cases, 20% more cases per pathologist per year after having gone digital. Second point worth mentioning, perhaps in this paper, would be that pathologists, once they go digital, they do not really want to go back to an analog workflow. So the advantages that a digital workflow brings about are far superior to the conventional analog workflow in terms not only of efficiency, but also in comfort, safety, and the overall experience is much more pleasurable, much more comfortable and efficient for pathologists compared to using the microscope. Right, so this call is entitled Boon or Vane, and I would say that artificial intelligence in itself is neither good or bad, because we have to bear in mind that artificial intelligence at the end of the day is a tool. And as such, it really is good depending on the task that we put that tool to work for. And that's the first key element that we want to put in mind. So essentially, artificial intelligence is an additional tool at the disposal of the pathologist. And in that sense, it's no different to immunohistochemistry or special techniques, special stains, or molecular testing. So as a tool itself, we have to learn to use it and we have to learn to interpret it. So it is no different in that sense, the output of an AI tool to perhaps an immunohistochemistry that we have to interpret, that we have to put into the context of the broader case. And we have to essentially, learn to recognize whether the expression, the immune expression that we are looking at is actually making sense, whether the expression is actually nuclear or cytoplasmic, or the right cells are being marked by the immune expression, etc., etc. In other words, we have to use our brain to interpret what that tool is telling us. And in that sense, artificial intelligence is no different. So that's the first key point to bear in mind today, is that artificial intelligence is just another tool at the disposal of the pathologist. Second point is that, we call it artificial intelligence and, we tend to associate intelligence with being sentient, with having feelings and having autonomous thinking and all of that. And perhaps this is too much to attribute to artificial intelligence today, because certainly artificial intelligence today is concerned with making predictions, okay? So may I suggest that, for those of you that feel somewhat uncomfortable about using artificial intelligence, how about if we change the name from artificial intelligence to something different, like predictive statistics? So again, that is mainly the concern of AI today, is to produce predictions about a certain case status. Is there a metastasis in this slide? Yes or no? Is there perhaps a cancer in this slide? Yes or no? That is the realm of AI in pathology at this point in time. So again, bear in mind that AI is an adjunct to the pathologist. AI by any means is autonomous today, and obviously it's very difficult to make predictions about the future, but certainly I don't see AI becoming autonomous certainly for pathology diagnosis, perhaps not in our lifetimes. It's very difficult, of course, to make predictions about the future, but the point here is that AI today, at this point in time, perhaps for the foreseeable future, would remain as an adjunct to the pathologist. Again, a tool that helps the pathologist perform a certain task, perhaps with greater accuracy, with greater efficiency, etc., etc. But let's not lose sight of the fact that AI is just another tool available to the pathologist to do what pathologists have to do day in and day out. And I think, having a better, more efficient, more accurate tool is great news in this day and age, because, if we look at these graphs, what we do see is that the number of pathologists keeps decreasing with time, as opposed to what happens in other specialties like radiology, anesthesiology, etc., etc. So we have fewer pathologists, essentially due to retirements that are not being replaced by new trainees. But on the other hand, we have more work to do. So as we can see here, the number of cancer cases keeps creeping up. And of course, we all know that cancer cases become more and more complex to report every day. Okay? So essentially, we have fewer people to do more work, and more work that is of greater increasing complexity. In addition, we're probably familiar with this document from the Royal College of Pathologists of the UK, where very, very, very small number of histopathology departments in the UK have sufficient staff to actually meet their clinical needs. So essentially, the evidence seems to suggest that pathology is under stress, is a profession under pressure. And at this point in time, I think we should welcome any help that we can get from any tools coming from AI that help us do our job more accurately and more efficiently. Right, let me give you some examples as to how can AI help pathologists in certain tasks. And let's get started with breast cancer sentinel lymph node and see how AI can actually help us there. Let's see what the problem is. And essentially, the problem is that we know that assessing lymph nodes is slow, it is time consuming, it's something that pathologists, generally speaking, do not enjoy doing because it feels sometimes like looking for a needle in a haystack. And the evidence seems to suggest that pathologists are not perfect at this task. This paper that was published some time ago actually essentially mentions that up to a quarter of patients that were diagnosed by a general pathologist get their end status upstage when the same patient is reviewed by an expert. So in other words, looks like, based on the evidence in this paper, that general pathologists actually tend to understage the end status of patients. And, it takes basically the review of an expert to get the right end stage. Again, because pathologists are human beings, it's inevitable that we all make mistakes. And obviously, the more expert that you're at a certain task, the better you're supposed to do it. Another paper, again, this is no new evidence. This paper was published, some time ago, and essentially what we do see here is that some AI models are actually, achieving a significant performance when it comes to diagnosing metastasis in lymph nodes. And in this paper, in this graph, we see here these lines that actually represent different AI models and the area under the curve of each one of these individual models. The green dot essentially represents a specialist, a breast specialist signing out cases without any time constraints. So in an ideal situation, a very qualified professional without any time pressure achieves a significant area under the curve. But unfortunately, this is not the real world situation because, most of the pathologists out there are not breast subspecialists. And certainly the majority of us have significant time constraints. And this is what it's represented by the orange dots here. So the orange dots essentially are generalists with time constraints. And what we do see here is that general pathologists with those time constraints actually become far less superior in their performance compared to certainly specialists with no time constraints, and even inferior to some AI models that actually seem to act in a superior, more accurate fashion when it comes to performing this task. So again, illustrates the point that pathologists are human beings, that they make mistakes, it's inevitable, and that these mistakes become more noticeable where, time constraints are involved. So how about if we have a tool, an AI-driven tool that essentially helps us sign out cases like this? So obviously this is a lymph node from a breast cancer patient, and obviously my job here as a pathologist would be to start zooming and panning all around the subcapsular area, looking for a small metastasis that might or might not be there. Difficult to know, right? How about if instead we just have a tool that we press a button, and if there is something there, the AI essentially highlights this region here. We just type there and we can see how the AI essentially is highlighting this region. Let me just get rid of it so we can see it better. This area that is indeed suspicious for small tumoral deposit. Very easy to miss, very difficult to measure, but with artificial intelligence and the digital tools, you can see it's incredibly easy just to do that and to essentially be able to reach the right diagnosis in almost no time. And in fact, we conducted an experiment that we published in the American Journal of Surgical Pathology last year, where essentially we selected 3 pathologists and we gave them a data set comprising 167 sentinel lymph node whole slide images. And essentially the pathologists read this data set twice, once without any AI assistance and a second time round, but this time with artificial intelligence assistance. And essentially what we found is that pathologists using AI were twice as fast, almost twice as fast at reading these cases, but also they made 12% fewer mistakes. So again, pathologists using artificial intelligence become not only more efficient, but also they become more accurate in their diagnosis. Obviously, the majority of these cases concern small tumoral deposits like ITCs and micromets, but not always. Again, because we all get tired, we all get distracted, and I think at this point in time, we should welcome any help that we could get from any tools coming from an AI model. Okay, let's switch gears now and let's see how AI can help pathologists signing out prostatic core needle biopsy cases. Because, a similar situation applies. We know that pathologists are not perfect at this task. And we have, a body of evidence that suggests that there is an error rate there when it comes to signing out this sort of specimens. Thankfully, the error rate is relatively small. According to these papers, it could be between 1.5% all the way up to 5%, depending on the data set and the situation, the context that you evaluate. But the point here is that the false negative error is 6. Obviously in pathology in general, and certainly in prostatic core needle biopsy diagnosis in particular. And, it is no wonder, because, if you have your desk that looks something like that on a typical day, and you have trays and trays and trays and cases, lots of cases looking like this, it is inevitable that we'll make a mistake sooner or later. It is inevitable. So how about if we had an AI-driven tool like this that essentially, highlights for us the regions containing invasive carcinoma, just like so, and obviously would also provide, a Gleason pattern assessment. So here, essentially, the AI is telling me the percentage of invasive carcinoma, the tumor length, the areas of Gleason pattern 3 and Gleason pattern 4. As you can see, they lighten up separately, so I can then review them at my leisure. And also detect perineural invasion. So we know detecting perineural invasion is slow, it's time consuming, but the AI can do that on our behalf, relatively easily. And of course, all of these results could be exported automatically to your laboratory information system, which would greatly accelerate your workflow. And in fact, the evidence using this sort of tool, can be summarized in these papers, as you can see there on this slide. I'm not going to spend much time actually giving you details there, but the common thread to all of these papers is that pathologists who use these sort of tools, again, become more efficient at their task, but also become more accurate. So their sensitivity increases together with their efficiency. So we can see here how perhaps in this paper coming from one of our collaborators in Portugal, they describe 25% shorter reading times. And as we can see in other papers, we see significant reductions in the false negative rate. Okay, so again, pathologists using these sort of tools become more efficient, but also more accurate, which of course is great news for pathologists and of course great news for their patients. This paper that was published earlier this week actually came from a group in the Netherlands. And essentially, they use this sort of tool prospectively, and they assess the need to request immunohistochemistry to confirm, to corroborate a diagnosis. Again, prospective use in real life patients. So, we can see that these tools have been used prospectively in real life situations with real life patients by some groups around the world. So the result of this study essentially is that the assistance of AI basically diminished significantly the need for immunohistochemistry cost. So essentially what you end up saving in immunos at the end of the day ends up paying for the investment in artificial intelligence, and of course leaves also some money on the table. So again, think of AI, going back to the points that I made earlier, think of AI as yet another tool at the disposal of the pathologist to basically help them sign up cases with greater confidence, with greater accuracy, and more efficiently. Okay, another task that pathologists do not particularly favor doing, which is mitotic counting. Again, because it is difficult, you have to keep a mental track, it's very easy to lose count, and we have to locate a hotspot, and locating a hotspot we know that is not always easy, it's greatly subjective. So how about if we had a tool where essentially the AI would locate the hotspot for us? So essentially if we click that label here, we see that everything that is not the hotspot fogs out and just highlights that region that always measures the equivalent of 10 high power fields, and essentially highlights in these little squares all the individual mitosis there for us to count. But not only that, the system only does the count itself. So here it's telling me that there are 21 mitoses in this 10 high power field area, and also highlights the individual mitosis for me. So I can easily go and individually check each one of those. So essentially the AI can be more objective when it comes to finding and locating the hotspot that we know that as humans we do this rather haphazardly. We do our best with the tools that we have today that are somewhat inappropriate for this kind of task. And in fact, the initial evidence that we have using these sort of tools seems to suggest that actually it is a reasonable tool for this task, in the sense that there is high degree of kappa agreement between the mitosis that the AI model has found and those that a pathologist would count. But also there are a subset of cases that would actually get upgraded in the Nottingham mitotic score when an AI tool is actually included, because essentially finding the hotspot is a bit haphazard, but the AI seems to be more accurate than the human eye when it comes to actually finding that hotspot. Okay, so we've seen now some scenarios in which AI can definitely help pathologists at these sort of tasks, but let's talk about now what AI doesn't do that well, because again, no tool is perfect and there's always limitations. So let's take a look at those limitations. And the first thing is that we have to bear in mind that AI acts as a diagnostic test at the end of the day, and a diagnostic test, when we design a diagnostic test, there's always this trade-off between sensitivity and specificity. And this is something that is intrinsic to all diagnostic tests. So let's see actually what that means actually in real terms. Let's imagine that we are actually designing a diagnostic test to help us diagnose diabetes on a population. So essentially we would have that population that we could order in two different curves depending on the blood glucose levels. Okay, so we'd have the healthy population here on the left hand side and the diabetic population. The problem is that situation in between both, because we would have a subgroup of that diabetic population that are actually diabetic but with relatively low levels of blood glucose. But despite that, they will go on to develop all the complications related to diabetes. However, we would also have a small subgroup of the healthy population that actually are healthy, they're not diabetic, they will not go on to develop any of the complications associated with diabetes, but they tend to have a physiological glycemia levels greater than that of the normal population, and sometimes overlapping with that of the diabetic population, as we can see here. Right, so let's assume that we design a test and we select a cutoff point arbitrarily where these two curves cross, right? So anyone with a blood glucose above this level will be called diabetic, and a blood glucose below that level will be called healthy. What's the problem in this situation? Well, in this situation, the problem is that this test is failing to diagnose this little tail of the diabetic population that actually have blood glucose levels that are pretty much overlapping with the normal healthy population. So what can we do in this situation? Well, what we can do here is to essentially bring the cutoff point towards the left-hand side and therefore ensure that we include everyone that is diabetic. So in other words, we make the test more sensitive. But the problem, the price that we pay with a more sensitive test is that essentially we also wrongly identify as diabetic to all of the population that is actually healthy but have blood levels above that cutoff point. Okay? Now, let's assume that we change the subject and we change blood glucose for histology and we change diabetes for cancer. The concept still applies. Okay? So it's important to realize that whenever we make a test more sensitive, we end up with more false positives. Okay? So somebody has to interpret those false positives and actually put reason to what the AI is telling us. Right. Let's take a look at some examples here of false positives. And these pertain to prostatic core needle biopsy areas highlighted by AI as suspicious. But we can see that for the most part, they refer to stromal areas or glandular areas that have relatively little complexity and relatively little difficulty in being called as what they are, actually benign. So, looking at another example, the AI is highlighting this focus here as being positive for suspiciousness. But in reality, what's happening is that there is a tissue overlap, there is a tissue fold here, and essentially the AI has been distracted by this result and is probably considering this nuclear hyperchromasia, which is purely artifactual, is due to a tissue artifact, but the AI doesn't know that. So it is important here that this gets reviewed by a pathologist to actually rule out here as what it is, basically, which is an artifactual false positive. This scenario here is a lymph node, and what we can see here is that the AI is highlighting this area that very likely corresponds to a germinal center. Okay? Similar situation here. Now we have a more clearly defined germinal center in which the AI is struggling to cope with perhaps the normal level of cellular atypia that we sometimes do see in normal, perfectly normal germinal centers. Another example with the same situation, germinal center, which is getting called falsely positive by the AI. So essentially what we can see in these examples is that for the most part, when we make a tool more sensitive than specific, we end up with a number of false positives. But for a pathologist, it's relatively straightforward to realize that this is a false positive occurring in the context of a more sensitive tool. Right, so to start wrapping up my session, the main points that I hope I managed to transmit today is that at the end of the day, AI in pathology is just a tool. It's another tool that we have at our disposal. And as such, it's neither good or bad. Okay? It's just a tool that is there, but needs to be interpreted by the pathologist's brain. However, what we've seen is that pathologists aided by these AI tools become more sensitive and more efficient when they do their job. As we've seen, like any other diagnostic test, AI is not perfect by any means. There are false positives, there are false negatives, and we still have to be able to interpret that. Pathologists, therefore, are required to use the brain when it comes to interpreting all of the results provided by an AI tool. And with that, I'd like to, again, thank you for your attention today. I hope you found my talk useful. If there are any questions, be very happy to take them via email. And hope to see you again. Thanks.